Our first presenter today is Dr. Rob Wedel, and Dr. Wedel has been a practicing physician in Taber, Alberta for the past 32 years. He has a passion for primary care reform and is the physician lead of the Chinook Primary Care Network, a network of 24 clinics and 110 family physicians. He's the co-chair of Alberta's Primary Care Improvement Steering Committee. Dr. Wedel has faculty appointments at the University of Calgary and the University of Alberta. He recently received the University of Calgary Faculty of Medicine Award of Excellence in Clinical Research and the Alberta Heritage Foundation for Medical Research Award for Organizational Vision and Leadership. And Dr. Wedel will share his experience of primary care reform in the province of Alberta. There's interesting parallels with our province, and his experience in a northern and rural context is certainly relevant for the Northwest LHIN. And his recent publication, Turning Vision into Reality, Successful Integration of Primary Healthcare in Taber, Canada, is included in your packages. So welcome to Thunder Bay, Dr. Wedel.
Good morning. Thank you for inviting me. I really appreciate the opportunity to visit Thunder Bay in the winter. I'd anticipated the beach and lake to create a coastal climate, which I guess that's what we're seeing today. Last night we saw the map of your health region, and Vincent from California and I were really sobered by seeing the vastness and thinking about what the unique patient needs and the solutions to those needs are going to be, and will clearly vary between Thunder Bay and Sioux Lookout and Big Trout Lake. And so the local innovation to those solutions is going to be really quite dramatic, and I think that is really a sobering thought. Thank you for that introduction. I suppose as being from away, that means I'm an expert, but I really wanted to say that I'm in full-time practice. I do half-time of my family practice in a rural community of about 7,000 people. There is 6.5 docs, and we take care of an area of about 20,000. So we're a little short of physicians. The other half of my time I spend seeing palliative patients across our region, and I'll show you our region a little bit later. It's much like yours. We have a central city of about 100,000 people. And the other half of our population is in rural communities spread around that. So there is some interesting likeness. When I thought about what I would say, there was a commercial on TV, and it was a group of little children in the back seat of the car whining, "Are we there yet?" And the adults maturely look at each other and roll their eyes and think, "No, we got a long way to go." And so thinking about primary care reform, and I use that term primary care reform because it's an old-fashioned term, and we've thought about calling it all sorts of things, renewal and renovation and primary care improvement. We've never really found a term that fits completely well, but it does show that we've had some movement. We are moving forward on this. I would say that the first time I ever read anything about some of the ideas around what we could do to improve things came from a paper that was published in 1994 in the Canadian Family Physician. It was actually written by 8 physicians from Ontario. So in a sense, even though these ideas are really international in their scope, Canada really saw this being born in Ontario, and some of the things that have been done here in Ontario have been really very innovative and very unique, and in a sense, rather than an expert, I really feel like we're kindred spirits in the sense that 5 or 6 years ago, one would be very impressed with the provincial variation and the breadth of the way provinces had approached the funding that was provided for primary care. I think we're starting to come together. And last night, one of the speakers mentioned that we still don't really have a clear vision of where we're going with this, but I think it's getting closer. And in answer to the question, are we there yet, I think we're starting to really see a more common goal and approach nationally. And heaven forbid that Alberta call anything the same as what you in the East would call it. Our primary care networks are really very close to some of the experiences that you've had. So what I thought I'd like to do is talk a bit about where we've been and some of the lessons that we've learned. And I thought it might be interesting to actually show some of the slides from our original project, which began in 2000. We were originally funded by Alberta Health. The federal funding that was available to primary care transition funding wanted reportable data in a year, and we thought we'd like to try something that was broader than that, and we didn't feel we could really do that justice in a year. So from 2000 to 2004, we were funded by Alberta Health and the Alberta Heritage Foundation to do something that was unique and intriguing in a rural area where you have some control over what happens. From 2004 to 2006, we had no additional funding, and it was sustainable. And that was also kind of a surprise to everybody, that we did this without ongoing funding outside the usual. And then when primary care transition funding became, or transfer funding became available from the feds, Alberta really still didn't have a clear vision of what we wanted to do with that, and they offered it out in what they called local primary care initiatives. Really not having a lot more definition than that, and to quote my colleague and friend Stephen Lewis, it was, reform primary care, pick a model, any model, we don't know. And so eventually, of the now 26 primary care networks that are present in Alberta, each one is slightly different. And we moved forward actually feeling like that was a breath of fresh air, some new funding, and we took a second step from what we'd originally done. And we're in the midst of learning some really interesting things from that. And then a third project came along, and that is called Alberta AIM. And I co-chair the steering committee provincially for that. AIM is an acronym. It means access and improvement through measurement. And it's an approach that I'll tell you a little bit about, and we're offering this out to the primary care networks in Alberta in an effort to allow improvement to happen, because it's so hard to really know where to start. There's so much to do. How do you prioritize and what do you choose? And so I'll talk a bit about that as well. So you'll recognize the slides that come from the older version of this. And so the Tabor Health Project was a 4-year project. Our community serves about 15,000. In almost all rural communities, you have two entities. You have the Regional Health Authority, which runs the hospitals, both the acute care and the long-term care, and manages home care and mental health and public health. And then you have the physician group, and we own our own building, and we provide services to the same patient population. And we thought, wouldn't it be interesting if we could actually integrate under one umbrella, under one management structure, a way to serve this patient population and try to, by integrating, decrease the duplication and decrease the fragmentation, and see if we could actually meet our local needs better by having some decision-making ability within our own community as compared to towing the line of the central agency. To give you some context, this is our Chinook Health region. It's right at the bottom of the province. So the bottom border is the US border. This side is BC. It's about 400 kilometers across. We have Lethbridge, which is about 100,000 people in the center, and then the other 100,000 people live in 10 rural communities surrounding Lethbridge. This created some interesting possibilities for us in that there were other communities of the same size as Tabor, about the same distance from Lethbridge, working under the same policy structure of the Regional Health Authority. And so it allowed us to actually create a control group so that we could make some interventions in Tabor and actually compare what happens to those where those changes weren't made. The other interesting piece is that it's about 45 minutes from Tabor to Lethbridge, which in a sense is a built-in patient satisfaction tool. And if people aren't happy with what we do, they just go to Lethbridge, and they're quite happy to do so. So we have been able to measure that as well.